You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri, and I'm your host, Dr. Jay Portnoy. It consists of a series of presentations by experts in allergy immunology and can serve as the didactic curriculum for trainees in the field. I hope you enjoy COLA.
Can see the slides, but we already went over the classification of the food allergies, right? So I'm sure you're going to have a talk on the Ig-mediated food allergy, which is a majority of the food allergic disorders. Although in infancy, non-Ig-mediated food allergies, at least for milk, account for about 40% of all of the infants. So that's the timeline that I was discussing for you. So you can appreciate this, really significant increase in the publications that occurred over the past 10 years. And we're really excited that we had in June of this year, we had the workshop virtual, which was rescheduled from 2020 when COVID intervened. But as I said, it's an important milestone. So the guidelines, and so we are here with the definition of the FPIES. So gastrointestinal symptoms of FPIES usually start within 1 to 4 hours, typically 2 hours after the ingestion of the food. And the typical is the emesis that is repetitive, forceful, could range from a few episodes like 20, 30, and it's frequently accompanied by lethargy, pallor, and in a subset of patients, diarrhea may be present later, within 5 to 10 hours, but there's no typical cutaneous or respiratory allergic symptoms. So FPIES reactions, unlike the classic Ig-mediated reactions, do not present with itching, hives, swelling, or coughing, wheezing, or sneezing. So, and the symptoms are quite nonspecific, and this accounts for frequent delay in diagnosis. So what's the prevalence? I mentioned before that the current estimates are about 0.5%. That's a study that was done by Ruchi Gupta, which provided the estimates of Ig-mediated food allergy about 8%. But in that population-based survey was one question about FPIES, and it says, has your child or have you ever been diagnosed by a physician with FPIES? This is a very specific and rare allergic condition. So we were really stunned to find the response rate of 0.5%. I have to tell you, though, that this is actually in line with other estimates from the other countries. And what was very interesting in that survey also, we found high rates of allergic atopic conditions as well as non-atopic, but a lot of Ig-mediated food allergy, asthma, seasonal allergies, as well as eosinophilic esophagitis among the patients who reported FPIES. The same study estimated adults with FPIES at 0.22% of US adult population. So again, this is a crazy number because we traditionally consider, FPIES as super rare condition and much less common in adults. So something is changing, or maybe this is an overestimation, I don't know, but certainly it raises interesting questions. Here are those studies from other countries that I mentioned before. So Israel study, cow's milk FPIES 0.34% in the first 12 months. A study from Australia was much lower reported incidence, but in that reporting system, FPIES was much more common than EOE or very early onset inflammatory bowel disease. And the Spanish study was 0.7% in the first 12 months, with cow's milk, fish, egg yolk as the most common trigger. So there's some sort of consistency here. So what causes FPIES? Like any other food allergy, any food can cause FPIES, but the most common triggers are cow's milk and soy in the countries that use actually those foods as infant formulas, oat and rice. And so depending on the population studied, there's majority of the patients are allergic to one or two foods, with a small percentage, about 10%, that have multiple, more than three foods that are being avoided. This is a study which presents more recent data from 2020, and grains have emerged as the most common single food group, followed by cow's milk, vegetables, fruits, soy, egg, meats, and peanut. Among grains, as I mentioned before, oats and rice, wheat, barley, and quinoa. Among fruits, avocado, banana, and apple are the top three. And among vegetables, sweet potato, peas, corn, and squash are the most common. So in general, the foods that are being introduced into the diet of the infant at the earliest. Globally, this is a figure borrowed from Antonella Gianferroni review on FPIES epidemiology. Milk remains the #1 trigger, followed by rice, followed by seafood. Interestingly, in countries like Mediterranean countries, Italy, Spain, Greece, seafood, fish, and shellfish are quite common solid food triggers among infants. Again, probably reflecting the dietary practices in that country, which introduce fish early into infant diet. The emerging food triggers in the US, as we mentioned before, the sort of the epidemiology of FPIES is changing. We are seeing more and more reports of peanut FPIES, of tree nut FPIES, and then also egg FPIES. So I was just curious. I was looking at my own patient population. Among over 100 patients with FPIES, 13.8% had peanut FPIES. And this is, from 21 to 22. This study published from CHOP in 2013 reported that peanut was found in 1.9% of their patients. So it appears that the time of the introduction of the food is a risk factor for FPIES, whereas it's a protective intervention in terms of preventing IG-mediated peanut allergy and egg allergy. So FPIES has several presentations. So the acute FPIES is the one that you are most likely to see. It accounts for about 90% of all of the patients, and those are the symptoms that start within 1 to 4 hours. Profuse vomiting, lethargy, pallor, but the patients recover very quickly. So within hours, and certainly within 24 hours, they're back to baseline. Patients with acute FPIES are big, robust babies that are thriving. However, if about 10% of patients have chronic FPIES, so 1 in 10 of the patients, and then those tend to be younger infants that are being fed with cow's milk or soy-based formulas, and symptoms evolve over the course of several days or weeks, and are just escalating when the feeding is continued. Then the patients become sicker and sicker. They are not gaining weight, those are the patients that are, in my experience, that end up in the intensive care unit because of the metabolic acidosis and other metabolic derangements. So in the guidelines, we really didn't have a lot of data about chronic FPIES. So we are, when we have a new edition of guidelines, we'll have to really characterize chronic FPIES better, understand spectrum of severity, because the cases that we see as allergies are the most extreme, spectrum of the patients who end up admitted to the hospital. But we don't know whether chronic FPIES in neonatal period might be, present as necrotizing enterocolitis. And because there are reports of FPIES causing pneumatosis intestinalis in those infants. So another phenotype, in addition, is so-called atypical FPIES. So those are the patients that have classic FPIES symptoms, but when you test them, they have detectable IgE to the FPIES foods. Usually, it's a low titer. And our studies, about 1 in 4 patients have had positive IgE by skin prick test or serologic testing, but they would still react with the, most of them would still react with the FPIES symptoms upon future exposures. Although some of those patients, especially if their IgE levels keep increasing, if they are, overall atopic, they might progress, switch from FPIES to the more immediate phenotype. And already in 2014, we have observed that 1 in 3 patients with FPIES will have IgE-mediated food allergy to another food. So having FPIES does not exclude the possibility of having anaphylactic reaction to another food. So keep it in mind that those patients are at higher risk for IgE-mediated food allergy also. FPIES in adults may happen, and as you know, 0.22% reported FPIES, but it was considered, very uncommon. Natural history has not been well described. The patients probably have long-lasting symptoms, and the symptoms are usually caused by seafood, so shellfish, mollusks, fish, but also dairy, wheat, and egg. So this is definitely very interesting. Why would that start, in adults, even, in their 50s or 60s? Symptoms are slightly different because the most prominent symptoms is that of the dramatic and very severe, so incapacitating abdominal pain, nausea, vomiting, up to the point of losing consciousness in some reports. Sorry, I have to turn this off. So FPIES in adults in that study by Jerry Gleich, which was reported with the shrimp. So interestingly, he was looking for patients with IgE-mediated reactions to shrimp. Of those, 21% reported exclusive gastrointestinal symptoms and had negative specific IgE. Majority were females, whereas, in infants, it's, sort of equal sex distribution. And the age of onset was about, could start in childhood or up to 60 years. And some of the patients had multiple reactions. And of those patients, of those 8 patients, 5 reported reactions to 2 or more shellfish. And you can see that abdominal pain was more common than emesis. So that's another sort of area that is a bit of a lacking area in the FPIES guidelines, because by guidelines definition, emesis is necessary for diagnosis of FPIES. So again, this should be revisited. So the guidelines propose those acute diagnostic criteria for acute FPIES. So the major criterion is vomiting in 1 to 4 hours with absence of skin and respiratory symptoms. And there should be 3 or more minor criteria. So more than 1 episode to the same food, repetitive emesis to another food, lethargy, pallor, emergency room visit for the reaction, need for intravenous fluids, or diarrhea that follows within 5 to 10 hours in a subset of patients. So, certainly if we can establish, if the patient meets those criteria, the diagnosis is confirmed. You could also always perform a food challenge to, like with any other food allergy, but rarely, we do rarely recommend confirmatory food challenges, as you can recognize the constellation of symptoms. As mentioned before, the chronic FPIES is a little bit more elusive. The guidelines state that the most important criterion for chronic FPIES is resolution of the symptoms within days following elimination of the offending food, and acute recurrence of symptoms when the food is reintroduced, with onset of vomiting with 1 to 4 hours, diarrhea in 24 hours, usually 5 to 10 hours. So essentially, once the food is eliminated from so the chronic FPIES develops when the food is ingested in high dose, daily. And then when the food is eliminated for at least a couple of days, and usually it's months or years, and then is reintroduced as either accidental exposure or the patient undergoes a food challenge, then you would elicit the classic symptoms of acute FPIES. So this is the same disease, it's just that the manifestations are determined by the frequency of ingestion. So most of the diagnosis of chronic FPIES is presumptive because very rarely are we successful in convincing parents to perform a confirmatory challenge for those patients with the chronic symptoms. So I would say suspect chronic FPIES in very ill young infants admitted to the hospital who are diagnosed with cow's milk or food allergy. I should mention that FPIES in general is very uncommon in exclusively breastfed infants. So the FPIES reactions are elicited by the direct feeding with the food. However, with Broke, we had Dr. Polk, we had a case of a patient that was actually became very, very ill when exclusively breastfed without any other, supplementation. So it is possible to have FPIES even in exclusively breastfed infant. So if you have to do a challenge for FPIES, the protocol is a bit different because of the potential nature of the symptoms and severity of the symptoms. About 10 to 20% of the patients may experience hypotension or even go into hypovolemic distributive shock. It is recommended that the challenges are done under physician supervision. It is considered a high-risk procedure, and it's preferable to have fluid resuscitation and access obtained in those patients. About 50% of positive challenges require treatment. So if you anticipate a difficult access or the patient has had very serious reactions in the past, definitely having an IV access secured before onset of feeding is advisable. And then because symptoms are so delayed, one of the approaches in the US is to either give one dose or 3 equal doses or 30 minutes, so much faster than for the typical IG-mediated food allergy. And there's this formula of calculating the dose of the food protein of between 0.06 to 0.6 gram per kilogram body weight, but generally not to exceed total of 3 grams of food protein. So again, this is not very straightforward, and potentially in the future edition of the guidelines, we should provide a better protocol for those patients. So the patients are being observed for at least 4 hours or up to 6 hours if their symptoms were delayed more than 4 hours in the past. For patients who exhibit symptoms, we observe for 6 hours, and they from the beginning of the challenge, and the patient has to be tolerating liquids by mouth without any problems. So that also, tells you that this is a very prolonged procedure. It's best done in the appropriate setting, not in the outpatient clinic. Here are some other FPIES protocols that have been published, and I think I just want to bring your attention to the one that was published from CHOP, where the patient was given a single dose, where the amount of food was about 1/3 serving for age. So it changes with the age of the patient. Patient was observed for 4 hours, and interestingly, after passing this initial challenge, the patients then increased the amount of food to the full dose at home. They had 17 patients reacted during the supervised challenge and 13 patients reacting at home, but fortunately the symptoms were quite minimal. And just vomiting and diarrhea, none of them required emergency treatment. So suggesting that, maybe giving lower doses and then, gradually increasing it may be an option to mitigate the severity of the symptoms during the food challenge, which, if you have observed any food challenges for food allergy, you probably know that the gastrointestinal symptoms are most unpleasant. They're not the most dangerous, but they're definitely most unpleasant. And following a reactive FPIES challenge, there's frequently a long, delay before the food is attempted again, just because the the high dose of food is administered, then the patient is very sick, and the symptoms are not relieved immediately with treatment, unlike with the IG-mediated food allergy. So it's a pretty unpleasant experience. What do we do with the patients that have atypical FPIES? So remember, this is a patient that had symptoms of FPIES but has detectable IgE. Well, I think we need to do a hybrid food challenge. So again, it's under physician supervision. We dose food incrementally per IgE food allergy protocol, but the total dose is usually lower, so not exceeding 3 grams of food protein. So this is less than a typical full dose of a challenge. So let's say a full dose for milk would be about a cup of milk, which is about 8 grams of milk protein for the IG-mediated food allergy. And so it would be 3 grams, so 3 ounces for the FPIES protocol. And then we observe the patients for 4 to 6 hours, right? So how do we interpret the challenge results? Again, based on guidelines, there should be symptoms, and then for the challenge, we would like to have at least 2 or more minor criteria, so lethargy, pallor, diarrhea, hypotension, hypothermia, or absolute neutrophil increase over 1500. So already with the first description of FPIES, it was this curious observation that there is a significant increase in the peripheral neutrophil count in the patients undergoing FPIES reactions. So this is one of the diagnostic criteria. We have documented it in our studies where we challenge patients in the research unit, and you can see that the patients who had reacted during the challenge, there's a significant surge in the neutrophils, but the patients who had resolved FPIES, so no reaction during challenge, had no change from pre to post challenge. So how do we manage? So we talk about diagnosis of FPIES, and I should go back a little bit to the food challenge just to say that we utilize those challenges mostly to evaluate for resolution of FPIES. So not really to diagnose. We sort of diagnose FPIES based on constellation of symptoms. Rarely would we recommend a challenge in an infant to confirm the diagnosis, but the challenges are very helpful when we monitor the patients, and usually you delay the challenges, so depending on how important the food is, how bad the symptoms were, but usually not sooner than 6 months, typically a year to 2 years from the most recent reaction or the challenge. So how do we manage FPIES? So long-term management is like with any food allergy, dietary elimination of food triggers, periodic reevaluation for tolerance with the food challenges, paying attention to feeding skills because the patients, infants with FPIES are at higher risk to develop problems with feeding. We do recommend timely introduction of complementary solid foods. We provide emergency plan for acute reactions. And then for acute management, obviously managing FPIES emergencies. Acute FPIES is, considered a medical emergency, and then the patient should be rehydrated. So the most severe reactions would require IV hydration, and patients may develop hypovolemic shock. But in patients that have milder symptoms, oral rehydration is an option. So how do we treat? So in the hospital setting, if there's IV, we would provide normal saline boluses. There is a strong inflammatory response during FPIES reaction, so we are methylprednisolone single dose given IV or IM can be helpful. And then ondansetron has been used, is being used widely right now as a sort of first line treatment for managing reactions at home as oral, but in the setting of in the hospital, we would ondansetron is most efficacious when it's given intravenously. Epinephrine does not work for those acute reactions. So if your patient develops vomiting during IG-mediated food challenge, epinephrine will really stop any gastrointestinal symptoms within minutes. for the FPIES, giving epinephrine without rehydration is not stopping vomiting. So we don't prescribe patients, prescribe epinephrine autoinjectors to patients with FPIES on a routine basis. As I mentioned before, patients may become quite sick, so they may require vasopressors and life support in the pediatric intensive care unit. In my experience, this is rare, and it has been I've seen it in the setting of the young infants with the chronic symptoms. So the guidelines, again, didn't really pay a lot of attention on ondansetron, although ondansetron since has become sort of a standard of care. It's an antiemetic, it's a serotonin receptor antagonist, and it's it's indicated for ages 6 months and older, and for vomiting for various reasons. So viral gastroenteritis, chemotherapy. Well, it's approved for chemotherapy. So oral ondansetron is definitely it's worth a try for milder symptoms at home. Dietary management, well, the food should be avoided strictly. There's no need for avoidance of traces or may contain, so precautionary labeling is not relevant for those patients unless you have somebody with a history of those extreme reactions to a tiny amount of the food, which is rare. So in studies with milk, the average amount of milk that triggered symptoms of FPIES was about 1 ounce, so 30 ml, or 2 tablespoons of milk. So symptoms during breastfeeding are uncommon, although not impossible, but we don't restrict maternal diet routinely unless there's symptoms in the infant. So either there are some acute symptoms or chronic symptoms, or even if the infant is asymptomatic but it's not gaining weight, then it's worth restricting maternal diet with preferably with continuing treatment. When breastfeeding is not possible, for those infants with the cow's milk or soy FPIES, extensively hydrolyzed formula is the first line, and the amino acid formula is the second line. So potentially those that have very severe symptoms might benefit from amino acid based formula. Dietary consultation, if you have an access to a registered dietitian with experience in food allergy, is very helpful. Some of those patients that have multiple, so about 10% of the patients would benefit. Well, all of the patients would benefit, but especially those who are breastfed or just starting to introduce food. But those that have multiple food FPIES definitely would benefit from the dietary consultation. And then, it is helpful to keep in mind the co-reactivity, or sort of, when you are selecting new foods for introduction. So let's say you have an infant that reacted to the first solid, which was oat, and now the parents are really, and it was a pretty significant reaction, and now the parents are really worried and reluctant to introduce any food. So, in such infant, it wouldn't be a great idea to introduce rice or wheat, because of this potential co-reactivity with other grains. So it would be better to start introducing fruits and vegetables. But remember, it's really important not to delay introduction of solids, especially in the past when there was a significant delay in introduction of solids. We were running into feeding difficulties in those patients with the extreme dietary restrictions, and the patient should be monitored for growth. There was a publication which appeared in the Annals in 2020 with Marion Groge as the first author. It was during the COVID pandemic, and we were worried about the patients not introducing new foods because of the concerns for acute reactions, and then also being worried about having to go to the emergency room. So there's a sort of a protocol that has been published that could be used for those very reluctant caregivers, to assist them with the introducing new foods, and starting with a small amount, like 1/4 teaspoon, and then feeding the child twice a day, so morning and lunch, and doubling the amount every time. So this is not for every food that has to be introduced into the infant. Just remember, most of them react to 1 or maximum 2 foods. This is for those infants, under certain specific circumstances where, there's a lot of hesitancy, a lot of, worry about having to visit the emergency room, or the parents who have been very traumatized by those reactions. And then, just sort of to help them build confidence. What's the important point here is that once they reach the serving size for their baby, they should continue that food for at least once or twice a week. So what frequently, the history that's frequently elicited when parents are introducing new foods is that they've introduced the food. So let's say, oat was introduced as the first food. It was okay, tolerated 3 to 4 times. And then they moved on to other foods, and then oat hasn't been fed for about 2 or 3 weeks. And then once the oat was again tried, then FPIES reaction developed. So there is some concern that intermittent feeding may be increasing risk to develop symptoms of FPIES. This is empirical observation. So, but it seems that based on the evidence from oral desensitization, in Ig-mediated foodology, that regular intake protects against food allergy and promotes oral tolerance. So that's what we would recommend for patients. So, I was asking, how many of you have actually seen patients with FPIES, and I'm sure many of you haven't seen any patients. But if you've seen some patients, the chances are that you were dealing with quite traumatized caregivers who are very worried about their child and what's going to happen. And the truth is that it's really helpful to put it in perspective and say that FPIES is a form of childhood food allergy. Majority of infants outgrow FPIES by age 3 to 5 years. So foods like milk or egg or rice or oat. So there is a rather favorable natural history. There may be an exception regarding the seafood FPIES. The studies from Spain suggest that the minority of those infants outgrow their seafood FPIES, but overall, the patients have really good prognosis. The patients that have, this is our study from Mount Sinai, where I used to work before moving to NYU, and the study showed that those that have IgE, they have atypical FPIES, may have a little bit more protracted course, and this was based on the observation from the cow's milk FPIES, in which we showed that the median age of resolution for typical FPIES was about 5 years, but cow's milk positive FPIES, so atypical FPIES, we didn't have anybody who developed tolerance. But I think, keep in mind that this is a highly selected population of patients referred to a highly specialized food allergy center. So this, certainly it should be evaluated further. I mentioned before that FPIES comes with comorbidities, so it is a non-Ig mediated food allergy, but it is associated with eosinophilic esophagitis, as well with atopic comorbidities. So many patients with FPIES may have a mild atopic dermatitis, but also Ig-mediated food allergy. As they get older, they become diagnosed with asthma, and they become diagnosed with allergic rhinitis, suggesting that there is a common predisposition or common pathways of allergic inflammation that are present in those infants with FPIES. A few words about FPIES pathophysiology. It's a bit of a complex topic, but we have done with my collaborator, Cecilia Barron at Mount Sinai. We've been interested in FPIES for many years, and we've been studying patients by obtaining peripheral blood from before and after challenge. Obviously, we don't have access to the target tissue, so patients with FPIES, with acute FPIES, are well in between the episodes, so there's no indication for performing a endoscopy and biopsies in those patients. But in peripheral blood, we're able to show a very strong innate immune compartment activation, as well as a pan-lymphocyte activation 4 hours after the symptoms onset in those patients. So it was quite interesting that monocytes lit up in our studies. More recently, we have used the systems immunology approach, and looking at proteomics. So, Olink assay allows you to measure a large number of serum biomarkers from less than 50 microliters of serum. So this really lends itself very well to studies in young patients, and you can see there variety of different biomarkers that have been evaluated. 14, the FPIES is shown as red symbols. Outgrown FPIES are shown as blue symbols, and you can see that there are specific biomarkers that have been significantly differentially expressed, so increased expression, and those the top biomarkers were in the Th17 pathway. So it was interleukin 17A, 17C, and CCL20. The protein that was differentially expressed was REG1A, which is expressed in pancreas and intestine. It actually regulates mucosal barrier downstream of interleukin 22, which is also a Th17 cytokine. And there's also increase in intestinal epithelial chemokines. So there's also increase in cytokines that are produced by monocytes, interleukin 6, interleukin 10, oncostatin M, leukemia inhibitory factor, and TNF alpha. So there's strong signal from both monocytes as well as from the lymphocytes. And we also, and I'm not showing it here, but we have in our other studies, we have shown metabolites of serotonin. So suggesting that, serotonin is increased or released during FPIES reactions, giving another rationale for using ondansetron. So there was increased signaling in eosinophils, neutrophils, monocytes, plasmacytoid dendritic cells, and CD4 T cells. And we also looked at the source of interleukin 17A in peripheral blood after stimulation, and the sources of IL-17 were T lymphocytes. So there's both innate as well as lymphocyte activation in acute symptoms, and still are struggling with the antigen specificity in FPIES reaction. But because there's no evidence of, for most of those patients, there's no evidence of IgE sensitization that would be, or IgG or IgD or IgA. We've looked at all of those subclasses that might provide this antigen specificity. So anyway, there's many unmet needs in FPIES. We have to learn dissect pathophysiology much better. We need a non-invasive laboratory diagnostic biomarker to sort of have a better, to be able to time the food challenges for resolution better. We would like to have a better oral food challenge protocol that is safer and less unpleasant for the patients. Obviously, we are missing strategies for prevention and to accelerate tolerance development, and drugs to more effectively treat acute reactions. So I mentioned that ondansetron is used, but it's not 100% effective. And obviously, oral ondansetron is less effective than injectable ondansetron. So it would be great to have like an ondansetron or other antiemetic autoinjector. And then at all the FPIES, there's a lot to be learned. So in summary, FPIES is a non-IgE cell-mediated gastrointestinal food allergic disorder. The estimates in the US currently are at 0.5% for children, 0.2% in adults. The FPIES triggers in infants generally reflect the first foreign food proteins that are introduced into the diet. This is cow's milk, cereal grains, and currently also eggs and peanut and tree nuts. Even though it's a non-Ig mediated food allergy, FPIES is frequently associated with comorbidities such as food allergy, asthma and allergic rhinitis, as well as the esophagitis and atopic dermatitis. If you see a patient with FPIES, please use the FPIES code. So what I do use FPIES code, and I also use a code for the specific food allergy. So let's say they're milk FPIES. I will say FPIES and then say milk allergy or gastrointestinal milk allergy. And so thank you for your attention. This is the spot. This is Dalmatian that is guarding the Hassenfeld Children's Hospital where I work. And the spot is a very good citizen because she's now wearing a mask during the COVID pandemic. And whereas you can see her pre-COVID without the mask. So I'm happy to take any questions.
Thanks, Anna, for that very comprehensive review of FPIES. I'm going to ask the audience first if they have any questions, and then I'll have one or two at the end of my own.
I have a question. Can you guys hear me?
Yep.
We can.
Okay. So in looking at the diagnostic criteria, it seems that FPIES can be really difficult to diagnose and differentiate from like gastroenteritis or reflux in an infant, especially in a family that doesn't report a clear food trigger. Are there certain like questions that we can ask in the history to try and differentiate and diagnose it from some of these other conditions?
Yeah, so that's a great point. And, the symptoms are non-specific, delayed. Usually it becomes, so you're right, like a viral gastroenteritis or some kind of infection is the diagnosis, the most common diagnosis of exclusion. But once if it happens more than once, the pattern becomes, obvious. So, usually, kids recover within hours, right? So once they purge that food, they are all better. And they don't have any other symptoms. Rarely they have diarrhea, but it's very short-lived. So, usually patients experience at least 2 reactions, or adults experience multiple reactions before this diagnosis is entertained. So there's a broad differential diagnosis, and especially like in the more severe reactions, it has to be followed. So you have to exclude, sepsis. You have to exclude potentially like depending on how severe the symptoms are, like surgical emergency with like ileus. So once you start, once you get if you think the parents will, I would say reflux is not easily mistaken with FPIES because the episodes are dramatic. Like you get this story. If you see the patient, you will get like they're frequently put down for a nap, and then they wake up or the parents find them crying in the crib covered in vomit, and they look pale, and they look ashen, and they are floppy, and and then they have that violent vomiting that is like they will describe it like exorcism across the room 10-20 times, and then everything calms down and the baby's back to baseline. So that's pretty typical. So you just have to ask questions, but you're absolutely correct. I always say that FPIES is like anaphylaxis, right? Like you have to recognize the constellation of symptoms. Especially in the emergency room, it can be confusing, and you have to rule out other potentially life-threatening emergencies. But it's being increasingly recognized by emergency room physician that this form of food allergy may be responsible for hypotension or even shock in their patients. But once the patients respond very quickly to treatment, and the symptoms are self-limiting. So take a good history, and just ask what they eat, and you can frequently track it back, tie it back to a specific food ingestion. Before FPIES was more there's less, awareness of this diagnosis. The patients were frequently diagnosed by their parents, after having 3 or 4 reactions.
Thank you so much. That was really helpful.
Other questions? I'll ask one here. With FPI challenges, let's say you're have a child that's at a likely age where they've outgrown it. So you're going to do a challenge to prove they've outgrown it here. Do you routinely obtain an IgE level to the implicated food in light of knowing that a percentage have sensitization, IgE mediated sensitization, and they could have had exposure to, to the food that they're trying to avoid through cross-contamination, accidental ingestion, etc. I've heard of cases of people who were FPIES who on a challenge did anaphylaxis and kind of after the fact. So
Yeah,
do you routinely do an IgE or skin test?
I do. It's not recommended by the guidelines. I would say that especially I think you have to do it in a patient that is atopic, like they have other food allergy, they have asthma, they have eczema, they have wheezing. That's for sure, because those are the ones that are more likely to have IgE. Sort of conversion. I don't even know whether it's conversion or but they may sort of switch from gastrointestinal to more immediate symptoms. So I think it just makes a lot of sense, before you go into that production. I think if they had multiple, especially if they're older and they have no atopic diseases and they had multiple reactions at an older age where they had classic FPI symptoms, it is much less likely that they would all of a sudden become IgE positive if they don't have other allergic atopic phenotype. But I think there's very little disadvantage to doing a skin test before the challenge, right? And confirming it's negative, and it gives you like peace of mind, and you sort of know what to prepare for. So I would do it. I would definitely do it.
Okay. And then also, and this reminds me of a case I just saw last week in my clinic. It's a child with rice FPIES, and he's relatively new to me, but at age 3 and 7, he failed FPIES challenges in somebody else's clinic. He comes to me at age 11. His IgE to rice is negative. I checked. And does one consider a challenge again, or is there at some age you just kind of go, no, this is for life? And I do it as an analogy of a peanut allergy. Some are going to outgrow it, most are not. Here, when you give up trying to do challenges and chasing it?
Never.
Okay.
No, seriously. I mean, Chris, we had patients who outgrew, who had like milk FPIES and soy FPIES, and outgrew it when she was 17 and 25. She was getting married and she outgrew her milk FPIES. So I think as long as your patient is on, I mean, I wouldn't force them to undergo food challenges every 2 years, right? But if they are hopeful and they are up, for trying, I would say don't give up. I mean, as far as I know, they're usually, what should I say? Okay, so there will be some people that they'll have it for life, right? And usually, like in my experience, those are the people that have really severe reactions. They react to like very small amounts of food. But if they are going to outgrow, they frequently will say, okay, now I'm able to tolerate like those things that before would have caused my symptoms. So they start tolerating like small amounts from cross-contamination or like in baked foods, etc. So especially if you elicit this kind of history of exposure without symptoms, I would definitely encourage a challenge. But that's the thing, like those food challenges can be quite traumatic, right? Because unless you could admit the patient to the hospital for a couple of days and just, really give them a very low dose and observe them for 4 hours, and then give them another very low dose and observe them for 4 hours, you end up giving them a set amount of food and not knowing what their threshold is. So, and then so you cannot really well control the severity of symptoms. So this is a long answer to your question. Don't give up. It's possible that they might outgrow even by age 25 or 30, but definitely those are the patients that there are patients that have more severe phenotype and more persistent phenotype.
Okay. All right, I appreciate that. So, well, for the sake of your time and everyone else, I think we'll have to conclude here. I really appreciate that you're here sharing all your wisdom with us today. As I'd mentioned to the group a little earlier, this will be recorded on COLA and uploaded in about 3 weeks. It just takes a little bit of editing time, so it'll be there. And then over the next year, we'll see frequent hits. Usually 500 to 1,000 people will be looking at this. So again, appreciate your efforts today and hope we can count on you in the future. I think that'll the end COLA for today.
Yeah, thank you so much for having me, and thank you for being patient with the technical difficulties, and thanks for your assistance. But it was my pleasure, and happy to participate in the future. Thank you. Bye-bye.
Okay, thank you all. Bye.